The chair calls up H.R. 5393 and asks the clerk to report.
H.R. 5393, a bill to amend Title 18 of the Social Security Act to ensure...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? The gentleman from Virginia, you're recognized for 5 minutes to speak on the bill.
Thank you very much, Mr. Chairman. My bill, H.R. 5393, the Transparency and Fairness for Pharmacies Act that I crafted with my friend from Georgia, Mr. Carter, will take important steps to help rein in and bring more transparency to direct and indirect remuneration, commonly known as DIR fees, and all pharmacy fees by pharmacy benefit managers, PBMs. It would require the Centers for Medicare and Medicaid Services, CMS, to create standardized quality metrics for health plans and PBMs to use when determining payments to pharmacies. PBMs often charge fees that are subjective to pharmacies based on how well the pharmacy performs. These performance measures are known as quality measures, but these quality measures are not transparent and are based on subjective standards, sometimes known only to the PBM. Pharmacies are forced to pay these fees in order to stay within health plan networks. These fees can be applied retroactively, sometimes months after the medicine has been dispensed. PBM pharmacy measures that are unfairly applied against all pharmacies have contributed to over 107,000%, have contributed to over a 107,000% growth in pharmacy DIR fees, according to CMS, undercutting pharmacy reimbursement and increasing patient drug costs. Currently, PBMs use quality measures that are often unknown and unpredictable, inconsistent, and beyond a pharmacy's control, which then figures significantly into the DIR fees pharmacies are forced to pay. Over time, PBMs have been allowed to operate virtually unchecked, leading to abuse of pharmacy performance evaluations and lack of transparency in pharmacy payments. My bill seeks to end these practices. This is one of the main issues I hear about when traveling throughout my district and the importance to help correct this opaque system. One small pharmacy in my district in Saltville, Virginia, says if they have to continue to dispense every medication for patients as they did in 2023, they have a conservative estimate that they will pay up to $80,000. This is a small town. $80,000 in DIR fees during the first 3 months of 2024. The amount this pharmacy must pay in DIR fees is more than they make, and they are worried they will have to close their doors if the issue is not addressed. These DIR fees have led to pharmacy closures all across the country and in my district as well. It is not just the rural community pharmacists that are hurting from this. Everything from independent to retail to specialty pharmacies. This is one small step to bring more transparency and certainty to pharmacists when dispensing drugs, but lots of work is left to be done. I am encouraged to see that CMS will be implementing a new Part D rule targeted at pharmacies in January of next year. This rule will require DIR fees to be assessed at the point of sale and hope to mitigate these outrageous DIR retroactive clawbacks. While I think that rule is well-intentioned, I am interested to see how it will play out and if it will truly stop these clawbacks while also monitoring the effect it has on patient premiums. We also need to do more to protect our pharmacies, and I would like to continue working with the committee on this effort to ensure PBMs can no longer undercut pharmacy reimbursement below the cost to acquire and dispense drugs, forcing the pharmacy out of network and many times out of business. I urge passage of this bill and hope that all of us can continue to work together to provide comprehensive reforms needed to protect patient access to pharmacies in our communities. And I yield back, Mr. Chair.